Welcome to the deep dive. We're jumping straight into the source material you've shared today. It's the kind of stuff you really need to get your head around.
Exactly. And our mission, as always, is to make it high yield, easy to remember, easy to grasp.
And today's topic is a big one, really critical: alcohol withdrawal.
That's right. And the material you sent over makes it crystal clear. This isn't just, feeling rough after drinking. It's serious.
Yeah, potentially life-threatening, a proper medical emergency, according to the note.
Absolutely. Needs treating as such.
Okay. So for this deep dive, think of us guiding you through these notes. We're going to break down, well, everything, what alcohol withdrawal actually is, why it happens,
Who's most likely to get it, how it sort of affects the body physiologically.
what else it might look like, how common it is, the actual signs and symptoms, and crucially, when they tend to show up.
And then, of course, how clinicians figure it out and manage it, what the outlook is, what can go wrong if it's not managed.
And we'll even touch on prevention a bit at the end, all pulled directly from your material.
It's going to be a comprehensive look, aiming for that solid foundation you need.
Right then, let's unpack this. First up, the definition. What exactly is alcohol withdrawal, based on these notes?
Okay, so it's basically the collection of symptoms someone gets when they suddenly or significantly cut down their alcohol intake after they've been drinking heavily for a prolonged period.
And like we said, the notes stress this isn't minor.
No, not at all. They really hammer home that it can be life-threatening and it's a medical emergency. The focus seems to be on acute withdrawal and the really severe end, delirium tremens or DTs.
Definitely more than just a bad hangover then. So why does it happen? What's the etiology described?
Well, the root cause is physical dependence. Essentially, after someone's been using alcohol heavily for a long time, their body, especially their brain, gets used to it. It adapts.
Right, that adaptation is the key thing. The material goes into the brain chemistry, doesn't it? Neurotransmitters and all that.
Yes, exactly. This is the how. So, chronic alcohol use affects the central nervous system. Specifically, it messes with two big neurotransmitter systems. GABA, which is generally inhibitory, like the brain's brakes,
Okay, the brakes.
and NMDA glutamate, which is excitatory. Think of that as the accelerator. Alcohol tends to boost the GABA system, the brakes, and dampen down the NMDA system, the accelerator.
Got it. So more brake, less accelerator, keeping things calmed down while the alcohol's there. What happens when you suddenly take the alcohol away?
Well, all of a sudden, those boosted brakes are less effective, and the dampened accelerator isn't dampened anymore. Your material clearly states this results in a state of hyperexcitability in the brain.
Ah,
You got less GABA inhibition happening and way more NMDA glutamate activity. So it's like, yeah, the brakes are off and the accelerator is suddenly floored.
wow. Okay, that breaks off accelerator floored picture really helps explain why you'd see things like agitation, tremors, even seizures. Makes sense. So if that's why it happens, who is most likely to experience this? What risk factors do the notes highlight?
The main ones mentioned are, well, first, a history of alcohol dependence itself, then, obviously, the level of use, heavy alcohol use, and crucially, if someone's gone through withdrawal before.
Ah, previous episodes increase the risk.
Yes, definitely. That's a key risk factor.
Mhm.
The material also adds that having other medical conditions or psychiatric conditions alongside can increase the risk too.
Right, complicates the picture.
Okay.
Putting this into context then, how common is this? What does the epidemiology data in your notes say, particularly for the UK?
Well, the source material paints alcohol misuse as a really significant public health issue in the UK. In terms of numbers, it mentions that something like 20 to 36% of people in primary care settings might have alcohol use disorders.
Wow, that's quite high.
It is. And specifically for alcohol dependence, it affects about 4% of adults aged 16-65 in England. It's higher in men, around 6%, compared to 2% in women.
So a decent chunk of the population potentially dealing with dependence. And the notes give some pretty stark figures about the risks if that dependence isn't treated, right?
Yeah, these numbers really bring home how serious it is. Untreated, the material suggests about 6% of dependent patients will get withdrawal symptoms.
Okay.
And of those experiencing withdrawal, up to 10% might develop delirium tremens, which is the most severe form. And then maybe a third of people having significant withdrawal could experience seizures.
Those are really worrying statistics.
Mhm.
Okay, before we dive deeper into the symptoms themselves, the notes mention differential diagnoses. What else could cause similar symptoms? What do clinicians need to rule out?
That's a really important point. Clinicians need to think about other things, like withdrawal from other drugs, obviously, Also metabolic problems, electrolyte imbalances, things like that. And neurological disorders need considering.
And distinguishing between straightforward withdrawal and DTs.
Yes, that's key too. Delirium tremens has its own specific features, so differentiating it from less severe withdrawal is vital for management.
Okay, need to keep a broad mind. Now, the clinical features, what does someone actually look like when they're withdrawing? And maybe the most crucial bit for remembering this, when do things happen? The material gives a timeline.
Right. So the general signs and symptoms listed are quite varied. You've got tremors, the shakes, anxiety, sweating, difficulty sleeping, insomnia, feeling sick or actually vomiting, agitation, hallucinations, seeing, hearing, or even feeling things that aren't there, seizures and delirium, which is that state of confusion. And the severity really varies hugely from person to person.
And that timeline is so important for spotting it and managing it. Can you walk us through the typical progression described in the notes?
Yeah, absolutely. This is definitely high-yield stuff. Symptoms usually kick off pretty early, typically around 6 to 12 hours after the last drink.
Okay, quite soon then.
Yeah, that's when you often see the tremor, the sweating, maybe a fast heart rate tachycardia, and that anxiety we mentioned.
Got it. 6-12 hours. Tremor, sweating, anxiety. What comes next?
Then alcohol hallucinos, the hallucinations, tends to appear a bit later, maybe around 12 to 24 hours after stopping.
Yep.
Withdrawal seizures, which are usually the generalized tonic-clonic type, the big fits, they tend to peak later again, often between 24 and 48 hours. The notes actually mention a peak around 36 hours.
Right, seizures peaking day 1 or 2, and then the most severe state.
Delirium tremens, the DTs, that typically peaks around 48 to 72 hours, so day 2 or 3.
Okay, so quick recap. 6-12 hours for initial symptoms like tremor, 12-24 for hallucinations, 24-48 for peak seizure risk, and 48-72 for peak DT risk. What exactly defines DTs according to the material?
The notes describe DTs by its cluster features. A really coarse tremor, significant confusion and disorientation, delusions, vivid hallucinations, often visual or auditory, plus physical signs like fever and a racing heart, tachycardia. It's a state of severe agitation and physiological upset.
Sounds incredibly serious. The material also mentions different ways people might present with withdrawal.
Yeah, it's not always straightforward. Someone might come in actively seeking help because they're already withdrawing. Or it could be unplanned, say someone's admitted to hospital for surgery or an infection, they can't drink, and then withdrawal starts.
Ah, okay.
Or it could be someone trying a planned detox at home, maybe, but finding it too difficult or running into problems.
And when assessing someone, what key bits of information does the source say are crucial to get in the history?
You really need to know the details of their drinking, how much, for how long. Critically, when was their last drink? That helps place them on that timeline.
Right.
Have they had withdrawal before? Because that increases risk. Any other medical problems?
Yeah.
Psychiatric history? What medications are they on, including any other substances they might be misusing? And what's their social situation like? Any support?
Okay. The notes also mention sometimes it's unplanned stopping because they just can't get alcohol due to illness or something.
Yes, that's another scenario to be aware of.
So it sounds like diagnosis is mainly based on putting all that information together, the history and the clinical signs.
Exactly. The material confirms it. Diagnosis relies mostly on a thorough clinical assessment, looking at the history, observing the symptoms. Lab tests are mentioned as supportive.
What kind of tests?
Things like liver function tests, checking blood alcohol levels maybe, and tests to rule out those other conditions or find underlying issues.
Okay, makes sense. So once alcohol withdrawal is suspected or diagnosed, how is it managed? What's the approach outlined in the notes?
The overall approach is described as a mix of medical treatment and psychosocial support. General supportive care is vital, monitoring their pulse, blood pressure, temperature, breathing rate closely, and addressing any other medical or psychiatric things going on.
And there's a specific class of medication highlighted as the main treatment.
Yes, benzodiazepines. They're stated as the first-line medication. They help control the symptoms like agitation and anxiety, and crucially, they help prevent seizures.
Which specific ones are preferred?
The notes recommend long-acting ones, like chlordiazepoxide, that's often known as Librium, or diazepam, which is Valium. These are usually given first line.
And how are they given? Is it a fixed dose?
No, it's usually a gradual dose reduction, a taper, typically over about 5 to 7 days. The actual dose needs to be tailored to the individual based on how severe their dependent seems, their weight, sex, liver function, things like that.
Are other medications mentioned?
Yes, a few others come up. Carbamazepine is noted as being effective for withdrawal symptoms, and it's particularly considered if someone has a history of withdrawal seizures.
Okay.
Gabapentin gets a mention for possibly helping reduce heavy drinking, though maybe less for acute withdrawal itself. And clemethazole is listed, but as a second-line option specifically for managing alcoholic delirium, the DTs.
And there was something important about a type of medication to avoid using routinely.
Yes, the material specifically advises against the routine use of antipsychotic medications for managing alcohol withdrawal.
Good to know. What about phenytoin for the seizures, sometimes used for other types of seizures?
The notes actually state that phenytoin is less effective for alcohol withdrawal seizures compared to using benzodiazepines or carbamazepine.
Right. There's one other medication, or rather supplement, that's mentioned as absolutely critical.
Ah, yes. Thiamine. Vitamin B1. This is vital. People who drink heavily are often deficient, and thiamine is essential to prevent a serious brain condition called Wernicke's encephalopathy.
How should it be given?
The material recommends giving parenteral B complex vitamins like Pigrunex, either into the muscle IM or into a vein, IV. This is especially important for prophylaxis to prevent Wernicke's. Oral thiamine might be okay if the patient seems well-nourished and the withdrawal is uncomplicated, but often the parenteral route is preferred initially.
Okay, so benzo's first line, possibly carbamazepine, avoid antipsychotics routinely, and definitely give thiamine. How do clinicians actually gauge the severity moment to moment to adjust the medication?
The material mentions a specific tool, the CIWA-R scale. That stands for Clinical Institute Withdrawal Assessment for Alcohol Scale, revised. It's a standardized way to score the severity of different symptoms, which helps guide how much medication, like benzodiazepines, is needed.
Right, an objective measure. And when does someone actually need to be in hospital for this? What are the admission criteria listed?
Hospital admission is recommended if someone has a history of complicated withdrawal, like previous DTs or seizures, or if their vital signs are very unstable despite initial treatment. Also, if they're under 18, if there are safety concerns like risk of harm to self or others or lack of support at home, or if they've already tried and failed a home detox.
Makes sense. And what about ongoing support or referrals?
Yeah, the notes mention referring to specialists if needed, like liver specialists, hepatologists, or psychiatrists, and that managing withdrawal is often just the first step in a longer-term treatment plan.
Okay. Looking beyond the immediate withdrawal phase, what does the material say about the prognosis? What's the likely outcome?
Generally, the prognosis section sounds quite positive, actually. It states that most people do recover with the right treatment and support.
That's good to hear.
Yeah. But the outcome does depend on things like how severe the withdrawal was initially, whether they have other health problems, physical or mental, and just their overall health status.
But it's not just about getting through the detox week, is it? Follow-up seems key.
Absolutely. Close follow-up is stressed as essential for long-term recovery. The notes mention things like ongoing counseling, support from self-help groups like Alcoholics Anonymous, AA is mentioned specifically, keeping the GP involved after discharge from hospital, and potentially using medications to help maintain abstinence or reduce the risk of relapse. Plus, sorting out any underlying medical or psychological issues is crucial for staying well.
Right. Now, the flip side. What if withdrawal isn't managed properly? What are the potential complications listed in the notes?
This is where it gets really serious again. The material lists several major complications. Delirium tremens itself is considered a severe complication, with that intense agitation, confusion, and cardiovascular instability.
Okay.
Other big risks include seizures, dangerous shifts in electrolytes, problems with breathing or the heart, respiratory cardiovascular complications, developing chronic health problems related to the alcohol use, and also an increased risk of developing problems with other substances or worsening mental health conditions.
It really highlights why prompt, appropriate treatment is so critical. Finally, the material touches briefly on prevention. Any strategies mentioned to avoid getting into withdrawal in the first place?
The main things mentioned are about early identification, spotting problem drinking early on. Also, screening patients who are admitted to hospital for other reasons to check if they might be alcohol dependent is highlighted.
Anything else?
Interestingly, yes. The notes briefly mention that following a ketogenic diet might potentially reduce withdrawal symptoms. Doesn't go into detail, but it's mentioned as a possibility.
Huh. That is interesting. A little nugget there. Okay, so we've really gone through the whole process based on your source notes from the definition, the brain chemistry, the symptoms and timeline, the management with benzos and thiamine, Prognosis, complications.
Yeah, we've tried to pull out the core information, the really high-yield points you need for a solid understanding or for revision.
Definitely. So thinking about everything we've just discussed, how common alcohol misuse is, as the notes say, but also how incredibly dangerous untreated withdrawal can be. Makes you wonder, doesn't it? What do you think might be the single biggest hurdle in actually getting people the help they need when they need it before things get that severe?
That's the really big question that sits behind all the clinical guidelines, isn't it? Access, stigma, recognition, lots of factors.
It really is something to think about. Well, that brings us to the end of this deep dive into alcohol withdrawal, drawing out the key information directly from the notes you provided. We covered the definition, causes, risks, the body's reaction differentials, prevalence, that crucial timeline of features, diagnosis, management, including key meds like benzodiazepines and thiamine, prognosis, complications, and a touch on prevention.
We really hope breaking it down like this has been helpful, giving you a clear, memorable summary of this important topic.
Absolutely. And don't forget, for more resources to help with your revision, you can check out pastthemsra.com and also freemsra.com.
Thanks very much for joining us for this deep dive.
And we'll catch you on the next one.